This is the first in a series of lectures that looks at the physiology underpinning cardiac arrest. We're going to take a deep dive into the why behind the how of how we deliver excellent cardiac arrest management. Now, we haven't really had any significant advancements in cardiac arrest since the introduction of the defibrillator many, many years ago. But ECMO, extracorporeal membrane oxygenation, which is basically a form of heart bypass, has helped change that. It's basically where we take a small machine, we place the patient in cardiac arrest onto heart bypass, bypassing the heart and providing oxygenated blood to the brain and other vital organs while we stop the clock and we treat the cause of cardiac arrest. Now, that has been game-changing in improving the survival rates of refractory cardiac arrest from less than 5% to around 33%. ECPR does work in a select group of patients, and it has been responsible for returning patients back to being productive members of society, back to their families, with many, many years ahead of them. But if there is one thing that I have learnt on my ECPR journey and providing ECPR to these patients, I have learnt that it's not about the ECMO. And that doesn't sound very sexy or heroic, does it? But ECMO really is the icing on the cake in cardiac arrest. It's another treatment option we have up our sleeve when other things have failed. Now, I can talk to you about all of the weird and wonderful evidence and the random things that you can do in cardiac arrest. I can talk to you about beta blockers, dual sequential defibrillation, steroids, or I can talk to you about what's really going to make a difference and how we can get it right. And honestly, after years of doing this and years examining the literature, it really comes down to the fact that we need to get the basics right and we need to be doing them well. Now, you'll notice and you'll see in the resuscitation science at the moment that some systems around the world will be advocating for a shock, go approach. Basically, give 2 shocks to these patients and get them to an ECMO-capable centre as quickly as possible, because what they're doing is prioritising ECMO CPR. Now, there are going to be strategies that are suitable for one region and not suitable for others. And this is very much going to be dependent on the geography, the skill set of the emergency services providers, and the hospital capabilities. But despite this, in systems around the world that are starting to prioritise this method of resuscitation, you will notice that the patients that don't receive ECPR, their control group, those patients that aren't eligible for ECMO CPR, their survival starts to decrease. And why is that? Because what you do as paramedics matter. The first 15 minutes of a resuscitation are ultimately the most important. That is where you will see the difference between a patient leaving hospital neurologically intact or not. That meticulous attention to detail, getting the basics right with your ventilation, your IV access, the adrenaline administration, the compressions, the compression fraction, all of it, all of that excellent provision of ALS is what really makes the difference. As an ambulance service with the quality of our paramedics, we can definitely do better than a shock, go approach. Now, the Toronto Ambulance Service have a 37% survival to discharge rate for their refractory VF patients. We can definitely do that. What we want to see as a pre-care team is more and more patients getting a successful ROSC. We only want to use ECMO CPR when we have given the patients the absolute best chance of getting a ROSC with standard ALS. What we can do then is place these patients onto that form of cardiac bypass, ECMO, and we can stop the clock so the cause of the cardiac arrest can then be fixed and treated. But in order to do that successfully, in this particular patient cohort. We need paramedics to fly that plane. We need paramedics to keep it in the air while we try and fix the cause of the arrest. So you'll start to appreciate that when we're providing something like ECMO CPR, that both teams, the paramedic ALS team and the ECMO medical team, are equally as important to survival and outcome. Because without that excellent provision of ALS, maintaining perfusion to the brain and other vital organs, the ECMO CPR will not work. So with that in mind, for many years I thought, not another cardiac arrest lecture. We have ALS guidelines. What more is there really to know? We perform the algorithm and we hope for a good outcome. And if there's anything I want you to get out of this talk, it's to get curious and to realize that cardiac arrest is a complex pathology. There are various cardiac arrest phenotypes, so we do need to take an individualized approach to that patient. An approach that requires you to understand the physiology behind what is happening with each patient that is presented to you, so that you can apply the guidelines in an effective and successful way. You need to understand the heart-lung interactions, the patient anatomy, the pathology, and how they all interact to impact on the cardiac arrest physiology that you're seeing in front of you. Performing CPR without measuring the effects is like flying an aeroplane without an altimeter. But even if we get everything in the chain of survival perfectly right, early effective bystander CPR, defibrillation, ALS, we know that we don't get it right every time. And that's because every patient is different. The algorithm is fantastic. It gives us a structure upon which to base our management. But that management guideline is not meant to be linear. And if we're only looking at the algorithm, then we're probably missing out on the bigger picture. That algorithm is a scaffold given to us as clinicians. We are responsible for adding the layers, designing the floor plan. We have this big toolbox available to us for applying that algorithm and prioritizing management within that ALS structure based on the individual patient presenting in front of us. We are learning that personalized hemodynamic directed CPR or targeted CPR can potentially improve the outcome. And for that reason, I think we need to start reframing the way that we think about cardiac arrest. We need to start placing more of an emphasis on the clinical feedback that we are receiving, checking the effectiveness of our interventions, and applying that continual assessment and reassessment, because cardiac arrest as a pathology is so dynamic. Did you know that the heart will start to move in the chest based on what the lungs are doing and the fluid shifts as the cardiac arrest progresses? How many of you have thought about checking whether your compressions are effective? Is this something that we really think about when we are doing CPR? The need for a more individualized approach is even recognized in the most recent American Heart Association guidelines on cardiac arrest management. So with that in mind, let's start thinking about and talking about our goals of care in cardiac arrest. What matters when performing compressions? What are our endpoints? What are we trying to achieve? We want good cardiac output, don't we? We want to achieve a coronary perfusion, so provide oxygenated blood to the myocardium so it restarts again. And we want to achieve cerebral perfusion, provide oxygenated blood to the brain. So with that in mind, this lecture series will start to build on a framework for those goals of care that need to be achieved within your resuscitation and provide you with that toolkit to check the effectiveness of your intervention and assess, particularly at the end of the resuscitation, whether you hit the mark, nailed those goals, and what you can do better next time. Click the link for Lecture 2, where we start to think about forward flow and how our compressions will influence the amount of perfusion and blood flow that the patient is receiving during resuscitation.